नमस्तुभ्यं वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा पद्मपत्रविशालाक्षी पद्मकेसरवर्णिनी नित्यं पद्मालयां देवी सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Yeah. Good evening, everyone. I welcome all the delegates to this webinar. So today's topic is on congenital photosystemic shunts, and to present that, we have two eminent speakers today. So first going to be Dr. Megha Sheth. She is one of the very dynamic person, and just yesterday, she did in another forum, one full lecture, and today she is going to give another lecture. She is very much interested in both the pediatric and the adult cardiac imaging. She also did observership in pediatric cardiac MRI at Children's Medical Hospital, Dallas, Texas, a couple of years back. And I welcome Dr. Megha Sheth. I also welcome Dr. Bhavik. He did his MBBS from PJ Medical College. He is basically a pediatric cardiologist, and he is one of our proud product from Amrita Institute of Medical Science. So he was very active during that period itself. So I welcome Dr. Bhavik. So today, now going to be, and we are planning to have it as a three different session. So first, Dr. Megha going to discuss about the basic radiological imaging in congenital photosystemic shunts. Then Dr. Bhavik will discuss on the what are the clinical features and the overview of the physiology of these things and the basics of the treatment. Then finally, they're going to be a case discussion. So before going to the topic, many people may be wondering why a photosystemic shunt, which is an abdominal radiology imaging in a cardiac radiology forum. Okay, so those who don't know about this, a very, very important condition, even though it is a abdominal condition, like there is a basically connection between the portal vein and the systemic circulation, which we seen in the other conditions like cirrhosis, but that is acquired shunts, whereas this we are going to discuss about the congenital shunts. So many of the physiologies are remain same. And the two important areas where a cardiac radiologist is very much interested in knowing about the photosystemic shunts are one is it can produce what is known as the hepatopulmonary syndrome. It's very, very important physiology by the radiologist. And the second thing is the portopulmonary hypertension. Okay, so rest of the things we know, and try to look at these things, two important things which we are going to discuss in detail, and the when to look for these features and what are all the imaging findings in various types of congenital photosystemic shunts. So without wasting much time, I call upon Dr. Megha. She is going to discuss about the imaging findings in congenital photosystemic shunts.
Thank you very much, sir, for your kind words. We'll
start. A very good evening to all of you. Hope you all are safe, healthy and happy as we emerge slowly from the second wave of COVID. So we very often discuss, we have discussed in our presentations, in our conferences, in our webinars, that we, depending on institution, we need to modify our protocol so as not to miss Abernathy, PAR, photosystemic shunts. So we thought, let us combine all those cases and we'll try to give you a detailed overview of not so discussed topic till today. Okay, so myself, Dr. Megha Sheikh, along with my colleague, interventional pediatric cardiologist Dr. Bhavik, will try to give you a comprehensive overview of congenital photosystemic shunts. First, I will start with anatomy, embryology, classification, and imaging, and then Bhavik will take over with clinical features, manifestations, and management part. And then together we will go through a few cases. Okay, so let's start. We start with congenital photosystemic shunts, an often missed entity. So what we will go through in this talk is, first we'll go through normal anatomy, embryology, followed by classification systems of congenital photosystemic shunts, imaging, and why it is important to diagnose. So first we see the normal anatomy of portal venous system. This is splenic vein with its tributaries. This is superior mesenteric vein with its tributaries. They combine to form portal vein, which at porta divides into right and left branches. This is the schematic representation of the same thing. Now we see the normal anatomy of the systemic venous system, wherein we have bilateral common iliac veins. They combine to form inferior vena cava. This is infrarenal IVC. We have right and left hepatic veins joining. Then we have the suprarenal infrahepatic IVC. This is the hepatic IVC. These are hepatic veins. Then lastly, the suprahepatic IVC that drains into the right atrium. Here is the schematic representation of the same. Okay, so what is the normal embryology? Most of the development takes place between the 4th to 12th gestational week from the vitelline and the umbilical venous system. See, these are the paired umbilical veins, right and left umbilical vein, and these are the paired vitelline veins, right and left vitelline veins. The right umbilical vein involutes completely, whereas there is selective involution of the left umbilical vein and parts of the vitelline venous system that forms the portal vein, as well as the ductus venosus that carries fetal blood from portal vein, bypassing the liver to inferior vena cava during fetal life, and after birth it forms ligamentum venosum. Okay, so any aberration in this selective involution process or any persistence of abnormal communications results in development of congenital photosystemic shunts. Similarly, the development of IVC is also complex. IVC develops from subcardinal veins, also in close relation with the portal vein. So any abnormal persistence of these fetal communications also results in development of congenital photosystemic shunts. Now we come to imaging modalities. First of all is Doppler ultrasound echo. It is a very useful modality for initial evaluation of congenital photosystemic shunts. It is easily available, allows a detailed evaluation, also gives functional information, which is very important, can be easily performed even at bedside or intraoperatively also. But sometimes due to lack of proper entire evaluation of the entire system, it needs to be supplemented by CT or MR or any other cross-sectional imaging prior to closure by either device closure or surgical closure. Okay, so as I said, USG Doppler ultrasound is very useful for intraoperative assessment as well as for follow-up. See, this is a case here. There is communication between portal vein. This is the communication. Okay, we can see portal vein. This is the communication. It was communicating with the IVC. So this is a photosystemic shunt. This was another case here also. We can see the communication, dilated portal vein and the communication between portal vein and IVC. Okay. Next comes, this is also a case here also. The left portal vein is draining into IVC. We can see the dilated left portal vein. This is the communication. Okay, next comes CT. CT is a preferred technique for evaluation of photosystemic shunts due to its excellent spatial as well as temporal resolution and high quality three-dimensional reconstructions. Drawbacks are ionizing radiation, then lack of functional information, but it is performed in fraction of seconds and it gives beautiful images, which I'll show you later on. Then comes MRI. MRI, again, the advantages are what we have in general, that is lack of ionizing radiation. It gives functional information also, but its spatial and temporal resolution are less as compared to CT. It is a lengthy examination and not easily available. So what we do is USG in Doppler for initial screening, intraoperative assessment as well as for follow-up. CT is for confirmation prior to device or surgical closure. Now for CT we need to change the protocol. In our institute we do two phases, that is first arterial phase and the second venous phase, wherein pulmonary veins, portal veins, everything is covered, and we take the second phase so as to cover the entire surface of the liver, so that nothing is missed. So finally, the imaging modality of choice will depend on the clinical context, patient characteristics, local availability and expertise. Which remember, if you are doing the CT, always take the second phase, which covers the entire surface of liver also. So now, what is the classification? Conventionally, congenital photosystemic shunts are classified into extrahepatic and intrahepatic. Okay, what are extrahepatic shunt? Any shunting between the portal vein or its tributaries and between the systemic veins and its tributaries prior to division of portal vein, that is called extrahepatic photosystemic shunt, also known as Abernethy malformations, and its classification has been proposed by Morgan and Superina. Okay, so they have classified congenital extrahepatic shunts into two types. See, type 1, again it is classified into A and B. Here, splenic and superior mesenteric veins do not form a portal vein but drain directly into a systemic vein. This is type 1A. Type 1B, in which a portal vein is formed, but instead of draining into the liver, it directly drains into the IVC. Okay, so that is type 1B. Traditionally, it is said that type 1 congenital extrahepatic shunts are characterized by congenital absence of portal veins. Okay, but this has to be proven by imaging. If it is not confirmed on conventional imaging, then invasive catheter angiography, you need to demonstrate that there is actual absence of portal vein tributaries or radicals. This is type 2 congenital extrahepatic shunt, in which there is a side-to-side communication, as you can see here, between portal vein and the IVC. Okay. Now, type 1 usually occurs in girls with associated malformations such as situs ambiguous, polysplenia or congenital heart defects. Type 2 shunts can be between any tributary of portal vein and IVC. So, it can be portocaval, gastrorenal, mesenterico-renal, splenorenal, mesenterico-iliac shunts. And depending on type of shunt, patient will have varied clinical presentation like rectal bleeding, etc., whatever the place of the shunt is there. Now, spontaneous closure of congenital extrahepatic photosystemic shunts has not been reported. So, and it is necessary to do the closure surgically or with device. Okay. Now, as I said, the type 1 shunts are called congenital absence of portal vein. See, I'll show you an example also, and we'll discuss later on also. You need to demonstrate the portal radicals or the branches of the portal veins in the liver, even if they are narrow. If you cannot demonstrate them on imaging or on CT or on MR, then while doing catheter angiography, as Bhavik will show, they will do a invasive balloon occlusion testing, in which if you see the portal radicals, then it is not congenital absence of the portal vein, even though it seems on CT scan that the portal vein is absent. So this demarcation is very, very important in order to label it as congenital absence of portal vein. Why this is important? This is important because if there is congenital absence of portal vein, then liver transplant is the only modality of treatment. On the other side, if there is no congenital absence, then we have a variety of options. Okay. So pathophysiology will be discussed in detail later on, but I just want to stress that the nutrient-rich portal venous gland, which was supposed to traverse to the liver, bypasses the liver. So liver is deprived of the nutrient-rich blood, so there is fatty degeneration, liver atrophy. This leads to multiple nodules in liver, which many a times we see coexisting in patients with congenital portosystemic shunts. Most of these are nodular degenerative hyperplastic lesions. Less commonly, it can be focal nodular hyperplasia or hepatic adenoma, or very rarely a carcinoma. Okay, now we come to intrahepatic portal systemic shunts. What happens is, if there is communication between right and left portal venous branches and or hepatic veins or IVC after the division of portal vein, this before and after the division of portal vein is very important in order to demarcate the extrahepatic and the intrahepatic portosystemic shunts. Okay, now Park et al. Divided the intrahepatic portosystemic shunts into 5 types. I'll show you. Out of these, the first 2 varieties are the most common. So type 1 intrahepatic portosystemic shunt, there is a single communication between a branch of portal vein and a branch of hepatic vein. In type 2, there is one or more communications between hepatic vein, that is hepatic vein, and the peripheral branches of the portal vein. When such communication is aneurysmally dilated, then it becomes type 3 intrahepatic portosystemic shunt. When there are multiple communications present between the portal vein and the hepatic veins distributed in both lobes of liver, then it becomes type 4 intrahepatic portosystemic shunt. Type 5 is the patent ductus venosus, that is communication between left branch of portal vein and the hepatic vein. If ductus venosus is normally present in fetal life and also for certain amount of time after birth. So ductus venosus is normally present in fetal life. If it persists after a certain amount of time, then it is called patent ductus venosus or classified as type 5 of Park congenital intrahepatic portosystemic shunt. I'll show you examples now. Okay, so this here we can see this is ultrasound image. The portal vein is dilated and here entire pathway is not seen, but it was seen to be draining into somewhere beyond into IVC, but above the surface of the liver. The exact delineation was not seen, so CT was done and we can see this is the portal vein, the tortuous course with kinking, and this portal vein was draining into the suprahepatic IVC. Okay, here also we can see the same thing. We considered it as type 1 congenital extrahepatic portosystemic shunt, but later on portal vein tributaries were found to be present on invasive catheter angiography, and so this patient underwent device closure. We'll discuss this case in detail also later on. This is a post-operative image, device closure. We can see device, and here this is also an image with device closure and it was properly fitted. Okay, now this is another example of portosystemic shunt between portal vein and IVC. This is the communication. This is dilated left branch of portal vein. What is important is here we can see a narrowed branch of right portal vein. This is very important to demonstrate and mention on imaging whenever and wherever we can see. This was another case. Here also we had an aneurysmal communication between portal vein and IVC. See, we can see here, this is IVC, this is portal vein, and this is the aneurysmal communication. This was another case of congenital portosystemic shunt. The VRT image of the same case, we can see the arrows demonstrate beautifully the aneurysmal communication between portal vein and IVC. Okay, this was again another case. Here also, see, this is the portal vein, this is the inferior vena cava, and this is the communication, and we can see some branches of portal vein going into the liver. So again, the thin red arrows show the IVC, white arrow the communication, and this is the portal vein. Okay, this was another case. Here we can see there is communication between portal vein at porta and IVC. We can also see the right and left branches of portal vein. This is a thin VRT image of the same patient where we can see this is the portal vein and that communicates with the IVC. What extra finding we see here are these multiple nodular liver lesions which I had talked with you or mentioned about. These are the liver lesions most likely due to nodular regenerative hyperplasia. Okay, so this is again I have demonstrated IVC, portal vein and the communication. Same patient VRT images, we can very nicely see the shunt. Okay, so these liver lesions generally they do not require, but sometimes if there is confusion we require their characterization by MRI. See what happens on T1 weighted imaging, these lesions are hyper intense, they are hypo intense on T2 weighted images. If we administer contrast, then on arterial phase there is hyper enhancement with retention of contrast in venous phase. So this is about the liver lesions. Again, this is an example of portosystemic shunt. Here we have the dilated right branch of portal vein, a narrow communicating channel between the two, and this is the IVC. The same thing is shown here in the coronal section. Again, this was an infant with communication between, this is dilated right branch of portal vein, this is the communication, and this is the IVC. The ductus venosus type of intrahepatic portosystemic shunt, we can see here, this is the left branch of portal vein, this is the small communication, and this is the middle hepatic vein. We can see very nicely this communication between portal vein and the hepatic vein. Okay, this was a case of another case, partial ABCD. Patient had absent spleen, absent splenic vein, and what we saw was that the superior mesenteric vein was draining directly into the IVC. See here also we can see this is the SMV draining into the IVC. This is again the VRT thin image of the same patient wherein the superior mesenteric vein was draining directly into the IVC. So it can be seen in association with, as I mentioned, it can be seen in association with congenital heart defects also. This was a 24-year-old patient who came for evaluation of congenital heart disease, and we found this abnormal communication, tributary of this portal vein, this abnormal channel. It was all the way connecting to left renal vein. See, this is, here is the portal vein, this is the entire tributary mapped. This is a reconstructed image, and here it was going into the left renal vein. This patient had double outlet of right ventricle as seen here, atrial septal defect, ventricular septal defect, and situs inversus in bronchus. Okay. This was 1 year female patient presented with pulmonary arterial hypertension. We saw this tortuous communication. This is the portal vein, and this entire thing is the tortuous communication that goes up, then descends downwards, and again it was draining into the left renal vein. I will show you the VRT image of the same patient. See, this is here. This is the portal vein. This is the portal vein. This is the communication that goes up and goes up, then comes down, 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 and here it drains into the left renal vein. So such communications, they are difficult to diagnose on ultrasound, and it needs CT or any other modality for confirmation. Okay. Now, this was a very rare case. This patient, 14-year-old patient, had congenital photosystemic shunt. We can see it very well here. But in addition, this patient had multiple arterial aneurysms from the splenic artery, from the common hepatic artery. So, such associations have also been found in association with congenital photosystemic shunt. Apart from splenic artery aneurysms, we may find coronary artery fistulas, primitive hypoglossal artery, and cutaneous hemangioma. Such rare cases and rare associations have also been documented in literature, like this one was published in December 2017. So, what is the main differentiating feature between intra and extrahepatic congenital photosystemic shunts? If anything is before the bifurcation of portal vein into right and left branches, any connection between portal vein or its tributaries and systemic vein or its branches, then it is extrahepatic, and anything after the division of portal vein is intrahepatic. But what happens many a times, the shunts are at porta, means there is communication between portal vein and IVC at porta with dilatation of right or left branch of portal vein. So don't go into just intra or extrahepatic shunt. What is more important is you mention the shunt, you mention the caliber, the dilatation, and most importantly, you mention whether you see right and left portal venous branches, however narrowed. If you see them inside the liver, don't forget to mention that. Mention any associated findings. If the patient has come for congenital heart disease, then mention all those things. So CT has the advantage that you can evaluate everything as a whole. Okay, so you should know what to look for in appropriate clinical setting. You need to modify imaging protocol with a second venous space covering the entire surface of the liver, and team approach is must for evaluation, treatment, management of such patients. I take this opportunity to thank, apart from thanking Bhavik, I would also like to thank Dr. Dinesh Patel sir, our HOD, Yashpal, our colleagues, Samir, Bhai, Milin, our technicians and team UNM ICRC, without whose support this would not have been possible. Thank you. Thank you very much.
That is a very nice presentation, Dr. Mega, with so very colorful images. So I request all the participants to send their queries in that Q&A session. So please send all your queries. Dr. Mega, so in your center, what are the common indications where you will do the scanning for the suspected congenital photosystemic shunts? So what are the common indications by which you will get a request or the common type of presentations?
Okay, so nowadays, since Bhavik and they have all joined, most of the times the indication that we get is suspicion of photosystemic shunt only. Maybe they have seen it on contrast echo or they are suspecting, and then CT has been advised before device closure, as I said. But yes, we do get incidental cases of photosystemic shunts also. The study has been performed for some other purpose, like undiagnosed pulmonary arterial hypertension, or the patient was referred on ultrasound for diagnosis of multiple liver lesions, or as I mentioned, in congenital heart disease, we are doing the CT for congenital heart disease, and if we do the second venous space, sometimes we end up with photosystemic shunts also.
Yeah. So one common thing which in our center also, so it is very important for the radiologist to understand is many times patient will be referred as a idiopathic pulmonary hypertension. And remember that so if you don't see anything in the lung, that doesn't mean that it is idiopathic. Okay, so one of the rare cause, but the very important thing is it is a treatable condition is the so, including the part of the liver. Of course, you'll be most of the time you'll be doing the CT pulmonary angio to rule out chronic pulmonary embolism. But this is one of the rare conditions where you can get the pulmonary hypertension. the presentation may be as a idiopathic pulmonary artery hypertension. And the other thing is because of the shunt, sometimes patient can present with a cyanosis with a echographically normal heart. Okay, so those who are regularly doing the imaging and intervention of these type of cases, those people will know that the referring clinician or the cardiologist, they know that they are dealing with this, and so that the specific request will come like not for to evaluation of the photosystemic sense, but in other places people should know about these entities. It's a very very important entity which are manageable, or many times it is completely correctable if you diagnose early. But there is no point in diagnosing very late when the patient sets in the already pulmonary hypertension. In that stage, sometimes it may be totally irreversible. Damage already occurred. Then at that point, no use. So you try to diagnose as early as possible. And other thing is, Dr. Megha, so what is your coverage when the request comes as the suspected photosystemic shunt, and how will you cover? Will you always include the chest and the abdomen, or only you'll do abdomen?
No, chest and abdomen both.
Yes. So now, what are we looking for in the chest? So why do we need to do the chest?
Sometimes on echo they mention pulmonary arteriovenous malformations also. Though
Yes.
CT we mostly find it negative, but still we do it. Maybe they are micro, so missed on CT.
Yes, yeah. So that is again other important thing is it's better to include the CT chest with a good arterial phase. But again, I want to stress that many times by echo wise they will refer as a pulmonary AVM by echo contrast wise. But sometimes we may not able to see the big aneurysms, but once in a while we may see multiple small peripherally located AV malformations that can be picked up. Of course, you can also assess the other features of pulmonary hypertension, like how severe is the pulmonary artery dilatation or branch pulmonary artery involvement. All those things also can be assessed. So it's better to cover the both the chest and the abdomen, and the abdomen needs to be covered in the venous phase. So if there are no other queries, we'll move on to the next part. I call upon Dr. Bhavik. So he's going to discuss about the clinical features and how to manage these cases, and what are the pathophysiology of this congenital photosystemic sense. Yes, Dr. Bhavik, please.
Good evening, everyone. I'm thankful to ISCI for giving me this opportunity. I'm going to present about presentation and management of congenital portosystemic shunt. Being a pediatric cardiologist in tertiary cardiac center in Gujarat, we often come across many patients with cyanosis or portal hypertension who on evaluation found to have structurally normal heart, but on detailed evaluation it turns out that these patients have a congenital portosystemic shunt. And since we have got this opportunity to treat these patients with congenital portosystemic shunt, I am happy to share my experience with you all. So I'm starting with my talk. My talk will cater following topics. First is CPSS physiology, clinical features and mechanism, associated abnormalities, diagnosis, management, intervention that includes transcatheter as well as surgical. So coming to CPSS, that's congenital portosystemic shunt physiology, it's important to know that whatever the anatomy or whatever the type of shunt is, the physiology remains same. So before talking about physiology of congenital portosystemic shunt, I will tell you about normal physiology. So portal vein carries the blood from gastrointestinal tract, spleen, gallbladder, pancreas, and it delivers it to liver. This portal venous blood contains nutrients as well as toxins. I have highlighted this toxin because these toxins are important in making in symptomatology of these patients with congenital portosystemic shunt. 75% of total liver perfusion is dependent on portal venous system. Remaining 25% comes from hepatic artery. Detoxification of these various substances occur in liver like ammonia, vasoactive substances, cytokines, and in CPSS what is happening, this portal venous blood is getting diverted to systemic veins. Along with that, I have talked about these toxins. These toxins also reaches the systemic vein, and because of availability of this toxin in systemic circulation, it will give rise to various manifestations of CPSS. In addition, what is happening, liver perfusion is also being affected, and that explains majority of liver related symptoms which are found in patients with congenital portosystemic shunt. Coming to clinical features and mechanism, first is antenatal. So there are documented reports which shows patients with CPSS has IUGR in absence of other causes which leads to IUGR, and reason behind that is altered liver perfusion during fetal life due to shunting of portal venous blood into systemic circulation. Postnatally, many children are asymptomatic, and it's an incidental diagnosis, but it's important to know these children also may get symptomatic if there are precipitating factors like GI bleeding or constipation which increases your arterial ammonia level. Coming to next symptomatology, I'll go through mechanism of its development and symptoms, what it is called. So first, in CPSS there is increased level of arterial ammonia which leads to altered neurological function, and this leads to the symptom called hepatic encephalopathy. Hepatic encephalopathy is present in 70 to 30% of children with congenital portosystemic shunt. When I say hepatic encephalopathy, it does not mean it is always severe. It can be mild variant as well. It is described, hepatic encephalopathy is described by neurocognitive dysfunction and behavioral abnormalities. It can have learning disabilities, extreme fatigability, seizures, failure to thrive, etc. Coming to next symptoms, portal venous blood is basically diverted to systemic vein and eventually it reaches the pulmonary circulation. So this portal venous blood which is reaching pulmonary circulation is rich in vasoactive substances, which is usually it's not about, which are not supposed to go into pulmonary circulation. So what happens, this vasoactive substances reaches the pulmonary circulation, it will cause vasodilatation of pulmonary vascular bed, which eventually lead to proliferation of pulmonary capillaries and development of diffuse tiny pulmonary arteriovenous malformation, which in turn lead to capillary blood being shunted into pulmonary vein, which will cause cyanosis, and this symptomatology is called hepatopulmonary syndrome. Hepatopulmonary syndrome is present in 10% of cases with CPSS, and it is responsible for significant cyanosis, dyspnea, easy fatigability, clubbing in patients with CPSS. Coming to next symptoms or presentation, portal venous blood being diverted to systemic vein and reaches the pulmonary circulation, but this time this portal venous blood is rich in vasoconstrictor substances, which after entering into pulmonary circulation it will cause pulmonary vasoconstriction and eventually lead to portal hypertension, and this is called portopulmonary hypertension. There is other theory which has been suggested or stated which indicates that there are development of microthrombi in pulmonary capillary bed and neointimal proliferation and fibrosis of pulmonary capillary bed, which leads to portopulmonary hypertension. 5 to 10% of children with CPSS has pulmonary hypertension. 15 to 60% of children with hepatopulmonary syndrome develops pulmonary hypertension over a period of time. It is associated with poor prognosis and reported mortality of 50%. Often it fails to resolve despite closing the shunt. So that is important. Pulmonary hypertension, if it is possible, it is always better if we close the shunt before the development of pulmonary hypertension. Coming to next presentation, portal venous system is responsible for 75% of perfusion in patient, 75% of liver perfusion. Remaining perfusion of liver is from hepatic arteries. Shunting of portal venous blood into systemic vein in patients with congenital portosystemic shunt will lead to compensatory increase in hepatic arterial flow into hypoperfused segments of liver. What will happen because of that? and this hepatic arterial blood is rich in hepatic growth factors like insulin, glucagon, hepatocyte growth factors, etc. This in turn will lead to development of regenerating liver nodules. So most commonly those are adenoma, focal nodular hyperplasia, hemangioma, etc. Regenerating liver nodule is present in nearly 25 to 50% of patients with congenital portosystemic shunts, especially in extrahepatic shunts. Various other presentations include malignant tumors like hepatocellular carcinoma, hepatoblastoma sarcoma, which is present in 4% of cases. Risk of hepatocellular carcinoma is equivalent to those patients who are having cirrhosis of liver. So that is a very high risk, and that's the concern if portosystemic shunt is not treated or closed timely manner. Gastrointestinal bleeding accounts for 1% of cases, and most of these patients who present with gastrointestinal bleeding, they have portal venous drainage into iliac veins, which will lead to colonic or rectal varices. Neonatal cholestasis and galactosemia, abdominal pain and hypoglycemia, unusual findings like Parkinsonism, autism, spastic paresis, hyperandrogenism due to hyperinsulinemia, pancreatitis, vaginal bleeding, urinary tract infections. These are unusual presentations of congenital portosystemic shunt. What are congenital portosystemic? As stated, it's a congenital defect. It is often associated with multiple other congenital abnormalities as well. Among that, most common is cardiovascular system abnormalities, and those include atrial septal defect or ventricular septal defect. Left isomerism is very common, and it has been documented that nearly 10% of patients with extrahepatic portal shunt has left isomerism. Other congenital heart disease include tricuspid atresia, tetralogy of Fallot, coronary artery fistula, as was mentioned by Dr. Megha. That is also common in patients with congenital portosystemic shunt. Other congenital disease include biliary atresia, annular pancreas, renal agenesis, cystic dysplasia of kidneys, crossed fuse renal ectopia, vesico-ureteric reflux, juvenile polyposis, duodenal atresia. It's important, various genetic syndromes are also associated with development of congenital portosystemic shunt, and most common out of that is Down syndrome, and we have come across 2 or 3 patients who were having Down syndrome and they had congenital portosystemic shunts. Other genetic syndromes include Noonan syndrome, Holt-Oram syndrome, Turner syndrome, Osler-Weber-Randau syndrome, Goldenhar syndrome, like that. Coming to the diagnosis is mainly imaging based, and majority has been taken care by Dr. Megha, but I will go through indirect clues which suggest that this patient may be having congenital portosystemic shunts are raised level of arterial ammonia. Patient, any child who is having cyanosis but is having normal heart, and on agitated saline contrast echo, there is appearance of contrast in left atrium after 2 to 3 cardiac cycle, which indicates evidence of pulmonary arteriovenous malformation and which may be secondary to portosystemic shunt. In echocardiography as well, with experienced hand and over a period of time, we are able to identify abnormal connection between portal vein and systemic vein. Ultrasonography is confirmatory in diagnosis of portosystemic shunt. CT scan and MRI is very useful in detailed anatomic evaluation and identification of portosystemic shunts. Conventional angiography has both value, diagnostic as well as therapeutic value. Transrectal scintigraphy is useful in quantifying the shunt ratio. So here you can see this is the echocardiographic subcostal window image where we found an abnormal connection between IVC and portal vein. Thus we can have indirect evidence and suggesting that this patient may be having portosystemic shunt. This is an echo image showing agitated saline contrast. Contrast appeared in RA, RV, and after 2 to 3 cardiac cycles, it appeared in LA, LV. As you can see, contrast in LA. So this usually never happen. Contrast will never appear in LA. If it appears, that means this patient is having pulmonary AVM, and that is an indirect evidence that this patient may have CPSS possible. Coming to management, I will cater management by giving answer to 5 questions. Those are: is the patient symptomatic? What is the type of shunt? How to close the shunt? What is balloon occlusion study? and what device to be used for transcatheter intervention. So coming to first question, is the patient symptomatic? If no, we can closely follow up this patient with monitoring of ammonia, and at any point when patient starts developing symptom, we can consider closure of this shunt. If yes, patient is symptomatic, then straight away go ahead and consider closure of the shunt. What is the type of shunt? So that is important. Intrahepatic shunts, it has been well described and documented that till 2 years, 1 to 2 years of age, this intrahepatic shunts may close spontaneously. But if it persists beyond 2 years, it is an indication for closure of the shunt. Extrahepatic shunt never closes, and it requires closure of the shunt at earliest. And why I am saying early? Because there are reasons for that. First, hepatopulmonary syndrome and pulmonary hypertension may develop very early in their life. Pulmonary hypertension usually doesn't regress despite closing the shunt. Chronic hyperammonemia and increased level of manganese will affect the developing brain of the child. Elasticity and plasticity of intrahepatic portal vein is very good in relatively younger patients, though there is a chance we may get very good result if we close at earliest. This is a therapeutic algorithm of CPSS, and as it suggests, any patient who is symptomatic, straight away go for intervention. If patient is not symptomatic, then decide whether it is intrahepatic shunt or extrahepatic shunt. If extrahepatic, go for intervention. If intrahepatic, you can wait until 1 year or 2 years and then decide for intervention. Now next question, how to close the shunt? Closing the shunt is by two options, whether it can be transcatheter or surgical. Transcatheter is always preferable because it is less invasive and less morbid. Surgical ligation is indicated when you are not able to perform, or it is not possible to do transcatheter intervention, like in side by side or shunts with side by side shunt. Failed transcatheter interventions, it is important that ligation has to be done near systemic vein or caval level. Why? Because our aim is to harvest or take care of majority as much as intrahepatic portal branches can be incorporated into portal venous system. Other thing, it can avoid, we have to avoid kinking of portal vein, which may lead to development of portal thrombosis. Other surgical options include liver resection, which is needed when there are multifocal intrahepatic shunts involving particular segment of the liver, and liver transplant in those patients who have multiple segments affected because of intrahepatic shunts, or there are multiple nodules or tumors in the liver, or type 1 Abernathy malformations, which Dr. Megha was suggesting, where there are no intrahepatic portal capillaries or branches, and in which balloon occlusion study fails. And this is a protocol of intervention and various surgical as well as transcatheter options available for patients with congenital portosystemic shunt. So what is balloon occlusion study? It is important to know. Balloon occlusion study is basically used to answer two questions. What is the portal venous pressure of that patient after you balloon occlude the shunt? So what is normal portal venous pressure? Normal portal venous pressure is usually less than 10 millimeter mercury, but in patients with congenital portosystemic shunt, you may get portal venous pressure as high as nearly 25 to 30 millimeter mercury once you close the shunt, and eventually it will come down once intrahepatic portal branches dilate and are incorporated into portal venous system. So cutoff of 30 millimeter mercury is taken, and if the portal venous pressure is less than 30 millimeter of mercury after balloon occlusion of the shunt, we can go ahead and close that shunt. If the portal venous pressure is above 30 millimeter of mercury, then that's alarming and you should not close those shunt directly. Rather, you should go in a staged manner. First, you just reduce the size of that shunt, and after 6 months or 1 year, you can close the shunt completely. Another question which is answered by balloon occlusion is whether there are intrahepatic portal branches or not. So once you balloon occlude and do the angio of that shunt, intrahepatic portal branches which are not visible in baseline angio of the shunt will be visible after balloon occlusion, and that gives extra confidence in doing intervention. So this is an example of balloon occlusion study where balloon, as you can see, balloon has been inserted from femoral vein. We are occluding the inferior vena cava. Note other catheter which has been inserted from internal jugular vein and has been parked into shunt. And after balloon occlusion, complete occlusion of shunt, we will check the portal venous pressure through this catheter. And this catheter is also used for doing angio as well. This is example of baseline angio. The catheter has been inserted from the internal jugular vein, shunt angio has been done. It's a large aneurysmal connection between portal vein and inferior vena cava, and you can see there are no portal or very minuscule of portal vein branches which are visible. And same patient, after balloon occlusion, portal vein branches has opened up quite a bit, which shows that portal venous branches are actually plastic and elastic, which may not be seen in pre-op imaging including USG, MRI or CT, but with balloon occlusion we will be able to see these intrahepatic portal venous branches. So coming to devices, these are the most common two devices which are being used in transcatheter closure of portal venous portosystemic shunt. This is an embolization coil. This coil is used for the shunts which are having a narrow fistulous connection, and these are vascular plug which is useful in patients even in narrow fistulous tract as well as a large fistulous tract as well. So being a pediatric cardiologist, we are well versed with various devices which are being used in patients with congenital heart disease, and because of that advantage we have been consistently using these devices in closure of portosystemic shunts as well. Those include patent ductus arteriosus devices, ventricular septal devices, atrial septal defect devices. So this is I'll go through few examples, and I will explain how we decide and which device has to be used. So this is an example in a 3-year-old child of portosystemic shunt. As you can see, there is a narrow fistulous connection between portal vein and IVC. This is a lateral projection, this is an anteroposterior projection, and in this image, as you can see, this fistulous connection is narrow. So this is an ideal case where you can use embolization coil for closure of this shunt. Same patient or same fistula can also be closed with vascular plug with more confidence, because embolization coil, if it is not selected properly, there is a chance that it may migrate proximally or distally. Same patient, pre-op and post-op images showing fistula closed with the vascular plug. Another example, this is an example of large fistulous connection between portal vein and IVC, and here you can see it is so large, it was measuring somewhere around 18 to 20 mm, and if it is so large, coil is out of question, and in this case only option is vascular plug or other congenital heart devices. But since we have a adequate length of fistula available, vascular plug may be an ideal device for this case. Same patient was fistula was closed with the vascular plug, and this is the pre-op and post-op images. Third example, this is an example of portosystemic shunt where there is a short connection and aneurysmal connection between portal vein and IVC. There doesn't have a fistulous connection, it's like a side-by-side connection, and as I have told, side-by-side connection, usually surgical ligation is a preferred option, but since we are using congenital heart devices very frequently, these devices may be ideal for such cases. If we use vascular plug in this case, it may protrude into either portal vein or inferior vena cava. So in this case, vascular plug is not a device which is to be used. So congenital heart device like atrial septal defect device or ASD device. ASD device advantage, it's a double disc device, so it captures both portal vein and IVC, and chance of migration of device is minimal. Second, it's a short length device, so the concern which we have that we should not occlude portal vein or IVC, that can be reduced or can be minimized by using ASD device. So same patient was taken into cath lab and the fistulous tract was closed with the ASD device, as you can see in this image. Coming to take home messages, so diversion of portal venous blood to systemic vein is responsible for majority of symptoms. Cyanosis in a structurally normal heart or idiopathic pulmonary arterial hypertension, always make an attempt to look for congenital portosystemic shunt. Intrahepatic shunts are likely to close, and it is always better to wait till 2 years of age. Long-term sequelae of portosystemic shunt is worrisome, and that is the reason it requires early intervention. Transcatheter closure of the shunt is very much amenable in experienced hands who has a good anatomy and physiology understanding of congenital portosystemic shunt. So this image shows how difficult it is to find water and how tedious process it is to find water in desert. But if you find water, it is always very satisfactory and pleasure experience. Same thing applies when it about congenital portosystemic shunt. It is very tedious and difficult process to identify, diagnose and manage a patient with portosystemic shunt, but end result is very good. Thank you.
Yeah, thank you, Dr. Pavik. That is a very wonderful explanation of the pathophysiology and how it is managed. It's very important for all the radiologists to understand the management aspect. Only we know what to look for in imaging. So, as he rightly pointed out, we can simply explain the pathophysiology of this congenital portosystemic shunt. Now, two basic things what is happening is because portal venous blood is diverted directly into the systemic vein without going into the liver. That is the basic pathology. So it is basically bypassing the liver. All the enteric blood is bypassing the liver and going directly into the systemic vein. So there are two things happening. One is the toxins which are supposed to be removed by the liver hepatocytes is not happening. So in this type of shunt, so he said that the most of the toxins from the intestine is directly going into the systemic circulation via this bypass. And the second thing is the important nutrients which liver has to get from the intestines. So that is not happening. So that's why now we are getting the liver changes. So a very important thing to understand is this hepatopulmonary syndrome and the portopulmonary hypertension. Even though there are lot more important complications of this the portosystemic shunts. So thank you, Bhavik, very nicely explained. There are a couple of questions from the audience. One person is asked how is the prognosis specifically related to pulmonary hypertension after device closure. So we had a case, they are telling they have a case where it worsened after device closure. So how can we explain that? So in specific relation to the pulmonary hypertension, I think this is a very important point of discussion.
So I already mentioned actually
yes.
portopulmonary hypertension actually carries poor prognosis, and there has been reported nearly 50% mortality despite you close the shunt. So portal pulmonary hypertension actually does not worsen after the device, but it may not come down after the device closure. So there are many case reports where it remains same, and over a period of time, patient may succumb due to pulmonary hypertension. But there are few reports, or we have actually one patient where we ligated surgically that patient, and we have been following up since last 4 years. And that patient's pulmonary hypertension did not regress completely, but from severe pulmonary arterial hypertension, it has come down to mild pulmonary arterial hypertension, and he is on pulmonary vasodilator therapy. At the same time, we had one case where we had bad experience, where after device closure, patient succumbed. But we don't know exactly pulmonary overall, if you see the data, pulmonary hypertension does not carry good prognosis, and once a while we may come across, we may lose the patient even after device closure.
Yeah. So that is a very important thing for the radiologist to understand this the pulmonary hypertension, which are very complex topic, and as you all know that for example, even in the left to right shunt cases, simple ASD or VSD which are easily treatable by both the surgical and intervention methods, and once the patient develops significant pulmonary hypertension, it be irreversible, and we cannot treat it completely. And the second question is, can you explain the procedure for two-stage closure?
Yeah, so basically what data is showing that initially we were thinking that 25 of portal venous pressure is taken as cutoff for whether to close that shunt or not. So what happens now? It has been included that 30 up to 30 millimeter of mercury it's acceptable. So if it is above 30 millimeter of mercury, that means there is a significant resistance to that portal venous blood to go into liver. So basically, intrahepatic portal venous branches are not adequate and not adequately elastic, that it allows blood from portal venous blood to reach into the liver. So what will happen? Patient will develop portal venous thrombosis, simple, because there is very sluggish flow. So in those cases, what they are doing two-stage surgeries. So either it can be surgical, it can also be transcatheter as well. So surgically, what they do, they'll take up the patient in operation theater, they'll partially ligate that shunt. They'll allow some blood from portal vein to flow into systemic vein. At the same time, they'll reduce the shunt flow or shunt ratio. So what will happen with this? Intrahepatic portal venous branches will open up over a period of time. They give time, nearly 6 months to 1 year. Yes. And after 6 months to 1 year, they'll take again patient either surgically or transcatheter. They will close this shunt after again documentation of portal venous blood. So this is how two-stage surgery works. And after first stage, they'll usually wait for 6 months to 1 year, and eventually they are able to close completely, and symptoms of portosystemic shunts come down. Yeah. So this is how they tackle patients with portal venous pressure above 30 millimeter of mercury.
Yeah. Can you do the same thing by intervention also? Do you have any specific devices where you can something like a fenestrator?
There are few devices. Actually, I have never done that, but there are few devices. They use covered stent with a constriction between. Yes. So what they will do? So that stent is a dumbbell shaped stent with a cover. So it will reduce the shunt ratio. The overall quantum of shunt will reduce by putting that dumbbell shaped cover stent, and this will reduce further quantity of flow which is going into systemic vein. So transcatheter it's possible, but personally I don't have that experience.
Okay. And the last question for this session is how are the patient with the portosystemic and splenic artery aneurysms are managed?
So yeah, as Dr. Megha has shown, we had a case who had large portosystemic shunt and splenic artery and other arterial aneurysm. Basically, this arterial aneurysm, it was not troublesome at that point. So patient was not managed for any arterial aneurysm. Patient was taken in cath lab, and that portosystemic shunt was closed for that patient. And arterial aneurysm has been on follow-up, and there is no as such any consequences because of that.
Okay, fine. Yeah, so then we'll move on to the third very interesting part of the session, that is the case discussions. So we'll move on to the case discussion.
Yeah.
Thank you, Bhavik, for your detailed explanation of clinical features, management, intervention, balloon occlusion test. After going through a comprehensive evaluation of congenital portosystemic shunts, we'll do a few case-based reading together. We'll discuss the entire case with its imaging. I'll go through the case, we'll go through the case together, and then Bhavik will discuss the management. So over to you, Bhavik.
We will try to do three case examples. In that, I will be talking about its presentations, initial diagnosis, imaging will be taken care by Dr. Megha, and I'll come back again and how we tackle that physiology or physiological shunt in cath lab. This is how our sequence of case example will be. So coming to first case, this is a 6.5-year-old girl weighing 15.5 kilo with height of 108 centimeter, which she presented to us with dyspnea on exertion and bluish discoloration of lips, fingers. On examination, she has SpO2 of 80% with pan-digital clubbing. On auscultation, CVS is normal. Echo was done, which was showing normal heart. And subcostal image, as I have told in my talk, with experience we are able to diagnose few abnormalities, and it suggested 7 millimeter window-like connection between intrahepatic IVC and portal vein, suggestive of Abernathy malformation. Contrast echo was done in that patient with agitated saline, which showed appearance of contrast in LA after 3 cardiac cycle. And for further evaluation, patient was advised CT pulmonary angiography for evaluation of pulmonary AVM or Abernathy malformation. And imaging, now Dr. Megha will be discussing about this case.
So CT scan was performed. I am showing you the second venous phase of this patient. We can see here RV, right ventricle, left ventricle, everything is normal in morphology. D-looped ventricles, normally related great arteries. We can see aorta and pulmonary arteries are comparable in size. Left arch with normal branching. The systemic and pulmonary venous drainage also appears to be normal. So nothing abnormal, no abnormal finding seen in the heart. As we go down, we can see IVC draining here, the IVC draining into the right atrium. Okay, we go below here. We see this abnormal connection. See, this is the portal vein. This is the portal vein. The portal vein is coming up here, and here there is the connection at porta between the portal vein and the IVC. This is the flush connection. Another thing, we can see this narrowed portal venous branches. Here also we can see. I hope the contrast and everything is clear to you. I'll also show you the sagittal images of the same patient. See, this is the portal vein. This is the portal vein. Okay, this is the splenic vein. Here is the portal vein, and we can see this is the connection between the portal vein and the IVC, very nicely depicted and in this patient. And these are the portal venous branches. Though narrowed in caliber, we can see them on imaging. Okay, so this was a type of congenital portosystemic shunt, Abernathy or extrahepatic type of shunt. Okay, so
next, with this imaging, what was important in this imaging, that it was an fistulous aneurysmal connection between IVC. It was very flush to IVC. There wasn't a fistulous tract, and immediately where it was joining IVC, there was a left hepatic vein and small portal venous branch which was exactly arising at the level of IVC. So this is the patient we have taken in cath lab. This is a femoral catheter introduced from femoral vein, and shunt has been hooked, and this is the angio, baseline angio, showing a dilated aneurysmal shunt which is connecting to IVC, and you can see there are very minimal branches of portal veins are visible in this shunt. So what is important now? Device planning is important. So this is a aneurysmal connection with side to side connection, and portal vein and IVC both are very close to each other. So as I told you in my previous talk, it's not a long fistulous connection. So in this case, amplatzer or vascular plug, which we have been used in previous cases, is not ideal case for this ideal device for this candidate. So with discussion, it was decided to use ASD device in this patient, which is having a short length and double disc, and with that plan this patient was taken into cath lab. So next step is balloon occlusion. Balloon has been inflated across IVC, closing the shunt. Another catheter has been introduced from internal jugular vein, and portal venous pressure has been documented. And in this patient, balloon occlusion shunt, post balloon occlusion portal venous pressure increased from 10 millimeter of mercury to 17 millimeter of mercury, which was in acceptable range. Next step, after balloon occlusion, we have done an angio, and now you can see clearly, if you can correlate with the previous image, the portal venous branches which were not visible, now it is visible nicely. That indicates there are intrahepatic portal venous branches present in this case. So next step is we took a long sheath. This is a long sheath from internal jugular vein. Here it's important to know that most of the portosystemic shunts are having a vertical orientation. So femoral venous approach is very difficult in such cases, and that's why we use internal jugular venous approach, which gives better anatomic orientation to the shunt, and it makes device deployment easier. So femoral venous sheath, the long venous sheath was taken from internal jugular vein. This is a 9 millimeter ASD device, atrial septal defect device, with which has been used to close this shunt. And this is the image taken for IVC angio, which was taken after device deployment, and there was a concern because I already told you it's a side-to-side connection. There is a chance of device protruding into either portal vein or IVC, and same thing happened. This device was protruding into IVC, but that's the another thing which is important during such complex or congenital portosystemic shunt device is it is always better to have a on intraoperative radiologies available which will guide us whether this device is looking adequate, whether it is protruding into portal vein, whether it is protruding into IVC or not. And in this case it was very useful. Our radiologist friend was with us intraoperative. He did on table intraoperative sonography of abdomen, and he's told device is protruding, but there is a monophasic flow across the IVC which rules out significant obstruction. And again we took a pullback gradient across the device of IVC, and the pressure gradient was nil. And with this important finding, we went ahead and released the device, and this is the post release device angio of IVC showing well flowing IVC. Although you can see there is an overlapping between device and IVC, but there was no gradient across, pressure gradient across this device, and sonography again confirmed IVC was unobstructed and there was a monophasic flow. This patient follow-up, 1 month follow-up, SpO2 improved from 80% to 95%. Patient was asymptomatic. Again USG abdomen was done on follow-up, and it is suggesting unobstructed IVC flow. Total 3 years follow-up has been completed for this patient, and patient is doing very well. She doesn't have any complaint at all. So coming to second case, this is an 11-year-old male child. He is weighing 23.4 kilo with height of 150 centimeter. He presented to us with bluish discoloration and dyspnea. His examination finding was SpO2 of 85%, pan digital clubbing, CVS again normal. On echocardiography, normal heart, but there was a suspicious of portal vein draining directly into right hepatic vein. That's why contrast echo again was done to identify pulmonary AVMs, and it showed contrast in LA, left atrium, after 2 to 3 cardiac cycle. And with this in mind, we advise CT angiography, CT pulmonary angiography to evaluate for hepatic vein as well as portal vein. And imaging part, again we will go to Dr. Megha, and she will talk about imaging of this patient.
Okay, so this patient was referred for CT pulmonary angiography. I have deliberately taken both phases of this patient. See, this is the first phase, arterial phase. Okay, we can see pulmonary arteries dilated, so changes of pulmonary arterial hypertension, right atrium, right ventricle, left atrium, everything else is normal. Systemic venous drainage, everything is normal. Just to show, in the arterial phase we can see something, but we are not able to diagnose. Now I will show you the venous phase of the same patient. See how important it is to take second or pulmonary venous phase, and that extending up to cover the entire surface of liver so as not to miss this rare congenital portosystemic shunts. Now we come, this is the, here is the portal vein, the splenic vein coming, this is the superior mesenteric vein, they combine to form the portal vein. This is the left branch of portal vein, and these are the, here we see a communication with hepatic vein. This is the left hepatic vein, right hepatic vein, this is the right branch of portal vein. So this is a ductus venosus type of portosystemic shunt. Again I'll show you the example, I'll show you again in coronal section. See, this is the portal vein, okay, this is the aorta. See, this is our communication, okay, this is between left branch of portal vein and the middle hepatic vein. This is the IVC. So again we were able to say that this is a ductus venosus type of portosystemic shunt, and the patient was referred back for further management.
So with this we took this child in a cath lab. So important thing to notice in this patient was it was a ductus venosus type of portosystemic shunt, so it's vertically down. So femoral venous approach is out of question. directly internal jugular venous approach was taken. So things which are important in this again is left hepatic vein. Our target is not to occlude left hepatic vein during device closure. So this is patient was taken in cath lab. This is a pigtail catheter which was placed from internal jugular vein into IVC. IVC angio, we were not able to find any abnormalities. It was a very difficult case. It was very difficult to hook or introduce into the left hepatic vein, but with great difficulty we entered finally into left hepatic vein, and from that with further negotiation finally we were able to enter into the portosystemic shunt, that is ductus venosus. So this is an angio showing a ductus venosus which is aneurysmal and it is entering at this point into left hepatic vein. So this is a large ductus venosus. On measurement it was measuring somewhere around 22 millimeter at the largest point, and narrowest point was measuring somewhere around 14 to 15 millimeter with left hepatic vein line flush to that point. So here again that thought what device to be used. Vascular plug, if you are planning, vascular plug comes up to the diameter of 22 millimeter. So that device was out of question for this patient. So we were left with devices which are used in congenital heart diseases. That comes PDA device or patent ductus arteriosus device or ASD device. Now problem with ASD device or ventricular septal defect device, these are a double disc device. So if I am selecting double disc device, the second disc will lie somewhere near left hepatic vein, and that is a concern, and there is high possibility I may occlude this left hepatic vein. So with lot of thinking we decided to close this shunt with PDA device, which is a single disc device. So I will go through further steps. So same patient, balloon occlusion was done and portal venous pressure was measured. Portal venous pressure was 8 millimeter mercury in the baseline. It increased to 16 millimeter mercury, which was in the range where we can close this defect or shunt. So again, after occlusion, portal shunt or the ductus venosus angio was done, and here you can see the portal venous branches has opened up again. That is important to note. What is important here, you can see post balloon occlusion the sluggishness of the blood or the contrast in the ductus venosus. That is important because this thing was important, and it was retrospectively important because it gave rise to a complication which we will come again in the further slides. So with lot of thought we introduce a long seat into the portosystemic shunt or the ductus venosus and a PDA device. PDA device is a single disc device. It has a single disc on one side, and other side it doesn't have the disc. So we deployed the device under USG as well as fluoro guidance. That was a 24 into 22 millimeter PDA device. Now 24 millimeter into 22 millimeter PDA device will have the disc which is around 30 millimeter. So that was ideal to close this shunt. So after deployment, this was not adequate. We confirmed by intraoperative USG and it was not properly fitting into the shunt. So what we have done here, we have taken the device back, recaptured the device and repositioned the device. So here you can see the device position has been repositioned. But what is important now, we have to look what is the scenario of left hepatic vein. So we again intraoperative sonography was done and it was showing left hepatic venous flow was not seen. So that means my device was occluding the left hepatic vein. So what we have done, we have recaptured this device again and we have pushed slightly inside so that we can salvage left hepatic vein. So finally with this maneuver we were able to salvage, and this angio shows the left hepatic vein is clearly seen, and on table sonography or intraoperative sonography as well was showing left hepatic venous flow was unobstructed. And with this we deployed this device, released this device, and the procedure was complete. But there has to be a complication. So this patient actually developed acute portal venous thrombosis on next day, very close to the device site. So that was very alarming for us. But luckily child did not have any complaint. So we heparinized the child. Heparin was continued for 72 hours. He was started on oral anticoagulation and aspirin and was discharged after keeping this patient for nearly 1 week in hospital. 15 days follow-up showed 40% recanalization of thrombus SpO2 improved from 80 to 85% to 91%. After 45 days, next follow-up sonography showed no thrombus. So thrombus was resolved and SpO2 improved to 98%. Patient was kept on oral anticoagulation for 6 months. Aspirin was continued till 1 year. 2-year follow-up has been completed for this patient and he is doing fine. And each and every visit we get USG abdomen done and child is doing well with no thrombus in portal vein. Coming to case 3, he is a 9-year-old male child, weight of 20.4 kilo, height of 136 centimeter, presented to us with cyanosis, SpO2 of 85% with pan-digital clubbing, echo structurally normal heart, but there was an abnormal fistulous connection between suprahepatic IVC and portal vein. So with this in mind, we send this child for CT angiography and imaging. Again, we'll go to Dr. Megha and discuss about imaging of this patient.
Okay, so this patient referred to us. Okay, now again we did I'm showing you the delayed venous phase. We see normal right ventricle, left ventricle, normal atria, normally related great arteries. So overall a structurally normal heart. As we go down, what we can see, we can see this is the portal vein. Portal vein is going through the ligamentum teres and it is going into the suprahepatic IVC, a tortuous course. Okay, I'll show you again in other sections also. See, this is our portal vein. It goes a tortuous course, narrowing here, tortuous, and then here it drains into the suprahepatic IVC. Again the same case. Okay, so this is the portal vein. This is the portal vein, sagittal sections we see. This is how here there is narrowing, but it is draining into the suprahepatic IVC. Okay, what else do you notice in this patient? We can see liver nodules. Okay, the nodules that we mentioned could be due to nodular regenerative hyperplasia due to diversion of nutrient-rich blood and also toxin-rich blood due to diversion of portal venous blood from liver. Now, one important thing is we presumed this to be a case of congenital extrahepatic portosystemic shunt type 1 because on imaging we were not able to demonstrate any significant portal venous branches. So we told the pediatric cardiologist that this is probably a portosystemic shunt type 1, but still they need to confirm it. So the patient was referred back with these findings.
So as Dr. Megha told, this was a patient with extrahepatic portosystemic shunt which is draining into suprahepatic IVC, and they were not able to find any intrahepatic portal venous branches. So that is important and that is very scary. Actually, if we are talking in previous years, it was an indication for liver transplantation, but nowadays it has been documented very often that even if you don't find portal venous branches in pre-op images, it is possible that you may find portal venous branches if you balloon occlude the shunt. So that is important. So but he was taken with that mind that we may have to do proper angio, and if we are able to see the portal venous branches, intrahepatic portal venous branches, we can proceed with the device. So patient was taken in cath lab. This is again the catheter from internal jugular vein, as the direction of the shunt is so that we may have to proceed with internal jugular vein cannulation only. So patient catheterized, the shunt was catheterized. This is a portal vein. This was the acute the acute band or stenotic portion which Dr. Megha has showed in imaging, and then ligamentum teres draining into suprahepatic IVC. So what is good thing here, it has a long fistulous connection. So here we are not much concerned about the device blocking either portal vein or intravenous inferior vena cava, but the concern here is whether this child is having intrahepatic portal venous branches or not. So with that in mind, this is another angio where we have done a simultaneous shunt angio and IVC angio, just to delineate how closely associated they are, so that we can keep in mind while deploying the device. So again, balloon occlusion was done, but what is alarming here, post balloon occlusion, the baseline portal venous pressure of 9 increased to 25. So that was alarming, and that would be we will be more cautious in closing this shunt, because we don't want to end up in patient having portal venous hypertension and sequelae for that. So with that in mind, balloon occlusion was done and balloon occlusion angio was done, and now it's very clear. You can see the portal venous branches has opened up, which was not seen in CT, and that was a major concern. So here we are at least happy that there are some portal venous branches which has opened up. But important thing, again, you can see this how sluggish the flow is. That means these intrahepatic portal branches are actually small size. It is not allowing portal venous blood to go easily into the liver. It is providing resistance to that. But with this in mind, and sluggishness of this flow and portal venous branches appearing post occlusion, we decided to close this shunt, and the shunt was closed with the vascular plug. That is a 16 vascular plug was deployed through the long sheath from internal jugular vein, and device was deployed. But what was happening? Again, the intraoperative sonography role, the radiologist was there on table. He did intraoperative USG, and he told that this device is protruding significantly into portal vein, and he is not able to see any flow going forward into portal venous branches, and there was severely sluggish flow into portal vein, and actually there was layering. So he was going into portal venous thrombosis. So device was repositioned, and again device was captured and repositioned to attain a proper position. After attaining proper position, again sonography was repeated, and after better hemodynamics and all portal venous, we were sure that we are not protruding into portal vein. We released the device. This is how after after device was released, this is the picture how it was looking. So with this borderline data, portal venous pressure of 25 and sluggish flow in portal vein after balloon occlusion, patient was started on intravenous heparin as a prophylactic measure to avoid portal venous thrombosis. Next day, USG abdomen was done. Position was adequate, but there was a residual flow through the device. So that was alarming, but at the same time, maybe child was lucky enough that he was not it became like a staged procedure. So shunt was not totally occluded, there was some residual flow, so it became like a staged procedure. So we were worried about 25 millimeter mercury portal venous pressure, but there was some residual flow, so it gave some time to this child so that he doesn't go into decompensation. Patient was discharged on aspirin clopidogrel. He had episode of epistaxis after 15 days, maybe drug related. So aspirin clopidogrel was stopped. SpO2 remained 85 only. There was no change in SpO2. 1 month patient was brought back again. USG abdomen was done, and it was showing same residual flow through the device, and SpO2 also was same. So we were slightly concerned whether we have done a right thing or not. There is a residual flow. What will be we will be doing? What if saturation doesn't happen, and if this residual flow persists? But luckily on 3-month follow-up, this same device totally blocked. There was no residual flow, and luckily child saturation improved to 97%, and we were happy seeing this saturation. After that, 4-month follow-up has been completed. Patient is maintaining saturation of above 95%, and she doesn't have any complications till now. Okay, thank you.
Yeah, thank you, Dr. Bhavik. So that's wonderful cases, very nice cases. You showed with a good demonstration of what exactly can happen in the lab under the role of radiologist. So there is one question from the audience. What dimensions should a radiologist mention in reporting portosystemic shunt, which can be helpful in deciding the device size or a type of the device? So what are the important parameters that needs to be reported?
I would say parameters like IV. First of all, how is the shunt? It's a fistulous tract or it's a flush connection between IVC and portal vein. Second, if it's a fistulous tract, how long? What is the length of that fistulous tract from portal vein to IVC or whatever structure it is draining? So third, portal vein, the fistula or that side by side shunt diameter. How is the diameter in 3 dimension or at least in 2 dimension? Because what happens, often this fistulous tract, uh, are expansile. So in one diameter it may be narrow, but in other diameter it may be large. So that helps in deciding what size or what type of device we have to use it. Third, very important, we have come across few patients where they are having IVC stenosis at the level of portal venous drainage or abnormal fistulous connection. So these are the cases where we may not be able to do devices, or there are some other options like surgical ligation. So we have sent 1 or 2 patients where they were having IVC stenosis. So that's not an ideal case for device. So we had sent this patient for surgical ligation. So I would say these are the most important parameters. Intrahepatic portal venous branches, even if they are not able to say, we are okay to demonstrate in cath lab. So mainly diameter, fistulous tract, where exactly it's draining, and how is the connection.
Yeah, I think that is the most important thing. And if we have fortunate to have a 3D printing models thanks to Dr. Magesh. So in a few cases of very complex diseases, even he could able to print out the 3D models so that to plan the procedures exactly. It was very useful. And we are also fortunate to publish our case series in the JACC cardiovascular imaging last year.
Right.
So with that, we'll come to the end of the session. I welcome Dr. Dinesh Patel. Welcome, sir. So can you now have a few words from you?
Good evening, sir.
Yeah, good evening.
How are you?
Yeah, fine. So any final comments, sir, from your side?
Yeah, Mega and Bhavik had done a wonderful job, and he's a very enthusiastic, hard worker, and doing well in our institute. And he's they are very hard workers, and overall webinar is excellent, and I'm thankful to Dr. Rajesh Kannan sir and Priya ma'am, and also thankful to ISCI body. They always try to bring something new every time with sole purpose of teaching. The constantly strive towards the academic excellence and work for the upliftment of the organization as a whole. It has always been great to be associated with them, and looking forward to their upcoming sessions. Once again, thank you, ISCI and team.
Thank you, sir.
Thank you, sir. Thank you very much. So I thanks Dr. Mega and Bhavik.
Thank you, sir.
Thank you,
The
sir.
entire Yuvan Mehta team for participating in this program. Dr. Priya, I also thank Dr. Prakash who is organizing this webinars every month. I also thank for hosting this event. Now Dr. Priya will announce the next webinar. Yes, Dr. Priya.
Yeah. So UNMC team was really did a wonderful job. The entire video presentation and everything were really superb. Very nice, interesting talk. Our next session will be on July 23rd July. It will be about cardiac sarcoidosis. Again, this time we have radiologist, a nuclear medicine person, as well as eminent clinical cardiologist who will discuss everything about cardiac sarcoidosis. In case if you have any suggestions for the other topics, please let us know. We would really try our best to get good speakers. Thank you and good night.
Yeah, thank you all the participants.
Thank you very much. Thank you, sir. Thank you.
Good night, everyone.